All right, so we'll wrap up our discussion of cost, quality, access. Apologies, last time I forgot to hit record, so there was no recording for last class. If you're listening to this and you've been listening at home, you'll need to get with your colleagues to talk about what we discussed in addition to the slides. All right, so I started to talk about lean. Lean is, so we talked about Six Sigma, which is statistical quality control, last time. And oh, hello, what are we doing here? All right, so statistical quality control we talked about last time takes and looks at a process, and a process is out of control. We use that word out of control, or that phrase, to talk about a process that returns unpredictable outcomes. And you don't want a healthcare process to be out of control, because that would mean that, for example, if you went to get a lab done, and let's say it's something simple like your cholesterol, which tells you how much fat you've got floating around in your blood. If you go to get your cholesterol tested, and one day you go in and, let's say you go in, you give blood, and they run the test once on your blood sample, and it comes up with an overall cholesterol score of 180. And then they're like, let's rerun that. And then it comes out with a cholesterol score of 160. All right, this is odd. Let's run it again. And it comes out with a cholesterol score of 220, right? So you've gone from healthy to normal to unhealthy without having, based on the same blood draw. That is an example of a process that is out of control. You're submitting. So let's say they drew a big enough vial that they could run it 3 times, and you're getting 3 different scores. That's a process that's out of control. So something is wrong there. Something is wrong in the way that the test itself is being administered. Same blood sample, 3 different outcomes. So that means something is wrong with the way the lab tech is, loading the sample, and something is wrong, or maybe something is wrong with the chemicals you're using to generate the result. Maybe something is wrong with the machine itself that you're running the sample through, right? Something is wrong there. So then we'd want to try to get to a point where we're getting a consistent result, even if it's consistently wrong. We want it to be wrong in the same direction. So rather than going 160, 180, 220, we'd want it to consistently hit, say, 150, 155, 120, 147, right? So that we're in a close zone that's maybe erring in the wrong way. And then we try to figure, all right, how do we get this to be more accurate? Assuming that maybe accurate was really 180. All right, so the first thing we do is we try to get the process under control. Then we try to move it to be more accurate. So that's statistical process control, originally and tied to a Six Sigma, which is is an approach, again, that is based on statistics. Lean is kind of its very close cousin that approaches, or that is used, I say close cousin, I should say. It's not the same approach, but they are often used together. So you'll hear about a Lean Six Sigma black belt, right? This is a cutesy term. People will they'll go to training, they'll learn this stuff. And so you'll have a chance, if you get into a manufacturing setting, or if you go into healthcare, this is common to be seen. Any place where they're doing a lot of processes, they are likely going to be implementing Lean and Six Sigma possibly together. And so if you get an initial training in Lean or Six Sigma, they call you a white belt. And then if you've worked on a couple of projects, you get your yellow belt. And then eventually you get your green belt once you've run a kind of a fairly significant project. And if you do a bunch of projects, of a very high value, eventually you become a black belt. And these are kind of cutesy things, but they're actually legit. If you get a chance to do any of that training, despite the cutesy titles, a Lean Six Sigma black belt in the real world is having that credential is a significant, that's a significant credential. You can make a lot of money in that world doing that kind of work. So what we were talking about a minute ago is Six Sigma. Lean is the kind of other way of approaching quality. And so I ran through these quickly last time, the idea that each of these represents a source of waste. So there's this great story. A Japanese lean management leader came to the United States to visit a US hospital, and they brought him into the hospital, and they walked into a waiting room where patients were waiting to be seen for a procedure or for a doctor. And he's looking around, and there's all these rows of chairs, and there's patients waiting patiently to get called in. And he said, "What is this?" I said, "Oh, this is the waiting room. Isn't it great? It's comfortable, good seats, And he's like, "This is terrible. It's a terrible situation. What are you doing making these patients wait on you, right? Is there any value to these patients for being here? How are you creating value by having these patients wait?" Right. So this is an example. So his vision of what he was saying is, from the customer's perspective, that step where you show up 30 minutes for you probably get when you get a doctor's reminder for an appointment for your dentist or your doctor, it probably says show up at least 15, 30 minutes early, right? What value is that to you to show up 15 to 20, 30 minutes early, and then they're running 20 minutes behind? So you're actually you're like sitting in the waiting room for an hour, right? Because they're almost always behind. That is a source of waste under lean. So the observation there was, if you look at your process from the customer's perspective, what does the customer want? Well, the customer wants to get seen by a doctor, right, quickly. We don't want it to have any defects, right? We want it to be done correctly. We don't want to have to go through a whole bunch of unnecessary steps, so motion. So, I mean, I don't know about you, but like whenever I go into the doctor's office, I wind up filling out like the same forms every time I go in, right? It asks, usually they're asking for my insurance. I'm like, nope, like there could be just a box. Has your insurance changed? No, check, done. Here, back. Instead, it's like, fill out the entire thing. Here's, give us your entire medical history. I'm like, you just saw me 6 months ago, why can't I just update, you on the last 6 months rather than give you my whole, I had surgery when I was 3, and you already know all this. Why don't you already know all this? Right. So that's examples in healthcare of excess motion, right? Of defects, and then also in healthcare, we often use people below their full skill level, and we've been working hard to try to work to there are some ways we're trying to work on that. But for example, nurse practitioners and PAs are, generally speaking, have the same outcomes as primary care physicians. There's been studies comparing the health outcomes of patients who are followed by primary care physicians versus nurse practitioners, and the evidence is pretty much you're okay being cared for by a nurse practitioner. So what that tells us is we could probably run a lot of our primary care with a lot more nurse practitioners and PAs, and have only the most sick and complex patients be followed by physicians. In other words, we're using a very expensive asset, a physician, right, who's got 4 years of medical school, 3 to 4 years of residency training, right? Versus a PA or a nurse practitioner that's got 2 years master's degree, 4 years of undergraduate, but so does the physician. So, right, you take somebody who's got to train for 12 years for their job versus somebody who's got to train for 6 years for their job. If you use that nurse practitioner at their full skill level, rather than using the physician at a level below her or his full skill level, you're wasting that skill set. So those are examples, right, in healthcare. So clearly defects, errors, that's bad. Not using people up to their full skills level, that's bad. And then waiting, we do a lot of waiting in healthcare. And so when you can look at what a lean management person does is they look at a process and they try to say, how can we pull out all these wastes? And they're wastes from the perspective of the customer. So in healthcare, from the perspective of the patient, right? Making the patient wait might be convenient to the physician, but that's a physician-centric model, not a patient-centered model. So Six Sigma and Lean, right, are interests. So here's an example of transportation waste in healthcare. So this is a example from my own life. My daughter, my youngest daughter was born in 1996 at Brooke Army Medical Center, at the old Brooke Army Medical Center. She was one of the last babies born in the old facility. Literally, she was born. We brought her back for her new baby or well baby checkup, her first well baby checkup, and went to the new building. And so the old building was built in like 1920 something. It's a pretty old building, but it was an old building even in 1996. So this is our first kid. So we didn't know what to expect, first time parents, terrified, wife goes into labor. We jump in the car. Well, she kind of waddles to the car. I jump in the car, right? I drive too fast over all of the railroad tracks, and my poor wife is like, oh, I'm miserable. She's like, stop. Like, I gotta get to the hospital. So we roll up to the hospital. The people are great. I don't mean to, but the process, I'm going to describe the process to you. So we show up, we roll in through the ED, they put her in a wheelchair, bring her up to the labor room, right? So we checked in, then they bring her into the labor room, they check her. Yes, you are definitely actually in labor. You're not having false labor. So we're going to labor here. Then so she goes through labor, right? And this is humorous. This is a teaching hospital. So like first one of the residents shows up to kind of verify that the nurse is correct, that my wife is in fact in labor. Then like all the residents who are on duty on Sunday night show up. So it's like 5 residents are in the room now, examining my wife in labor, right? And then they say, she advances to the point where she's ready to deliver. So then they take her and move her to the delivery room, which is a different room. So it's across the hall to a different room, where we're joined by, I don't know how many other, so all the residents, like a bazillion nurses. I mean, it was like I don't know, it was like a rock concert or something. We were all like crammed in there, my wife at the center, in all her glory, right? It's just the time when you want a whole bunch of strangers standing around you. Right, she delivers, successful, happy baby girl. Everybody was great, everybody's healthy. Then from the delivery room, she's rolled into a recovery room where she kind of gets cleaned up, and they get ready, get her, continue to recover. And then once they're like, okay, you're not bleeding, you're not anything, then they roll her into postpartum, which is where she then stayed for the next 48 hours. And in the postpartum, I will never forget this. The postpartum room was a room shaped like this table. It was a big rectangle. And there were two doors. One was here and one was here. And there were, I want to say like 10 beds in there. So there was like 1, 2, 3, 4, 5, 6, door, 1, 2, 3, door, 4, 5, 6, door, 7, 8, whatever, 7, 8, 9, 10, whatever, something like that. 7, 8, 9, maybe 9 beds. I don't know. There were a lot of ladies in there. Let me just say that. And they were all laid out like sardines with this, with feet. Like, so you would come in, so you'd come in the door here, and like, so my wife was down on the far end. So I'd come in here and I'd have to walk past lady, 7, 8 and get to 9, my wife down the end. So that's, and oh, by the way, this is in San Antonio, Texas. And it was like the 7th floor of the hospital. And so the ladies were all facing this way. And on this side was a big bank of windows facing west. So as the sun set, the light would beat in on all the ladies recovering, right? And, luckily this was January when my daughter was born, but I can only imagine what that had been like in August when it's like 110 degrees in San Antonio. So I'd come in, to see my wife, and I'd come in, and I'm like, how you doing? And get to my wife here in the end, right? So at least she had a modicum of privacy, but at some point in the first night, as she's trying to recover from giving birth, they bring in a woman who'd just been through a C-section, and this woman was in a lot of pain, so she was like groaning and crying, and then there's the other 8 women in there who are being kept awake, but it's just a goat rope. And the care itself was fine. It was good, I'm sure, and we made it through fine. But what we saw was a lot of, so this is an example. So, right. So one of the wastes of lean is this movement, right? So we're doing a process here, and we're doing a process here, and we're doing a process here, and we're doing a process here. Why is that necessary, right? Well, as it turns out, it's actually not necessary. This is no longer the standard of care. This is very much like 1950s socialized medicine. Today, so this was the process, right? Was the process on top is labor, delivery, recovery, postpartum. So my second daughter was born in Colorado a year and a half later. So we're not talking about like different centuries, right? Born in Colorado, wife's in labor, run down, grab her. I had just gotten to work, and she paged me. I used to have a pager, and goes, remember those? Yeah. So I had a little pager go beep beep beep, and pick it up, and it said, it said it was from my wife, and it was 911. So I knew I was important. So I call her, and she's like, I think I'm in labor. I'm like, all right. Turn around, jump back in my car, run home, pick her up. We run down to the medical center, and we check in, and they put her in. They bring her in. They check, yep, you're in labor. Bring her in. And they put her in one room where she labors. There's one nurse monitoring her. Her regular OB was not on duty, so one of the partners came in to deliver. That's fine. That is what it is. They did the delivery. They're like, all right, it's time to deliver. And the bed that she was in does this like transformer thing, and it turns into a delivery bed. Where they like get her up in stirrups and stuff, right? And she delivers my second daughter, beautiful, everything goes great. Then they do the transformer bed turns back into a regular bed again, and she recovers in that same room. So this is, and then does postpartum care in that same space as well. So it was. This quality of care was probably, ultimately the actual medical care was probably just the same, right? But the patient experience for everybody involved was 100%, 180 degrees different. Right? It was 100% better. We had privacy. Right? It was just eventually it was maybe, it was the nurse, who the L&D nurse, the OB, a pediatrician eventually showed up because once the baby is born, the OB kind of hands off the baby to the pediatrician. So we had this, fabulous experience in this one room. And oh, by the way, they had like a place where I could stay if I had wanted to, but I had to go. So I could have stayed in the room with my wife while she, recovered. The other one with the sardine can recovery room was like, no, you're out of here at 8 o'clock or something like that. There, visitors weren't allowed after like 8 o'clock, something like that. Whereas the other one had like a recliner that I could have stayed overnight if I had wanted to. I couldn't because I had to go home to take care of baby number one. So this is called an LDRP or an LDRP suite, right? And this became, this is kind of the standard of care. And it's less about the quality of the actual medical care, right? And it's more about the patient experience, which is important, right? Delivering a baby is a kind of major life experience for all involved. And this treats the woman in a way with more respect and more dignity. So whereas I'm sure at the old facility I described, we got perfectly good medical care, the patient experience was not that great. So LDRP eliminates one of the wastes of lean that we described by eliminating transportation and excess unnecessary movement. It's necessary if you build your building like that and you set up your practice such that you have to labor here and deliver here, recover here, and then do postpartum care here. That's a bad design. What you should do is change your design. And so what LDRPs did is they changed their design. So it's kind of fun. So in 2004, Congress, this is relevant for military folks. In 2004, Congress passed a law that said women who are covered by the military health system can choose to either have their baby through the military health system, or they can opt to choose a civilian provider. So for example, we were in the military at the time. So when my let me try to think. I guess when my first daughter would have been born, which was before this change. But had this change been in place, had this policy been in place, living in San Antonio, we could have chosen to have my wife get her OB care and deliver her baby through the military, so at the military hospital that I described, or she could have chosen to go out to the civilian economy where there are, lots of hospitals in San Antonio that she could have chosen to deliver at. At the time she gave birth, we didn't have this choice. But in 2004, we did. And so I was working at that point in time, I was working in Louisiana at a small hospital in Louisiana, a critical access hospital, sized hospital in Louisiana. And this law was passed, and we had when I first got there in 2003, our L&D looked like the top line here, like what my wife had experienced in San Antonio. And once we were told, hey, by the way, your patients can choose to either have their care at your facility, or they can go out to the civilian economy. And oh, by the way, we're going to penalize you if they do go out because we're going to charge your facility for their care that they're getting downtown instead of getting it with you. We very rapidly realized, and I imagine any of you young women who hope to eventually have, deliver a baby, which would you rather have? Would you rather go through the 4 stages of process that I described, or would you rather have a private room where you go in, deliver the baby, recover all in one place? Maybe you don't have strong feelings either way, but I think most people would say I'd rather go through an LDRP. So we built LDRPs. We changed the way we delivered care to match not the standard, again, not the standard of care in the sense of medical care, but in the standard of the patient's experience. So we greatly improved our patient's experience by rebuilding our L&D into LDRP suites. So that's an example of kind of lean process, as well as how policies change and affect the way we think through things. All right. So we've talked about quality, talked a lot about cost. Let's talk about access. So there are a number of ways to define access. Your book goes into these at length. I'll just cover them briefly, right? So availability is the idea that there's a service that fits an individual's needs, and that they can choose from. Accessibility means that the service is actually they can actually get access to it, so it is physically close enough. So that's a challenge in rural New Hampshire, right? Or in rural communities in particular, being able to get to a service, which is why critical access hospitals exist. The idea, critical access hospitals primarily serve rural communities where otherwise there might not be a hospital. So, the hospital up in Berlin that I always refer to is it's way up there. Right? There aren't a lot of other alternatives around it. So if they stop delivering babies at Androscoggin in Berlin, you'd probably have to drive an extra. If you lived in Berlin, you might have to drive quite a long way. It might be a half hour. And if you're getting ready to deliver, you don't want to have to drive too far. So available is the service that you need available. So OB is a great example of this, because there are places around the country where it's hard to find an OB. So so is the service you need available? Can you get to it, physically get to it? Whether that's because, so is that a challenge of geography? We've talked about the physician mismatch. There's too many physicians, or plenty of physicians in urban environments, not enough physicians in rural environments. So that's another one, right? What about disability? Right. So can you physically get to the building? Can you physically get to the provider? Is it affordable? So if the service is available and you can get to it, can you pay for it? Accommodation. So this is an important one that you may not think about now, right? But you will definitely think about once you have kids and a full-time job are the hours good? So if you're going to physical therapy, for example, do they have hours? And you've got to go a lot. Like if you get a serious injury and you've got to go to, say, physical therapy twice a week, right? Or 3 times a week. Well, if you've got to go to physical therapy 3 times a week and they don't have, early morning hours or late evening or like late afternoon or early evening hours, then you might have to take a whole day off from work. Well, that's an inconvenience. That might be more than just an inconvenience. That might make it, that might not make it possible for you to go, because you might have, if you're, we've talked about this a lot. If you're a rich person, you just take the time off, right? But if you're a poor person who doesn't have paid vacation or doesn't have a job with paid sick leave, you might just have to forego the care because you can't afford to take the time off. So part of accommodation would be, does the provider offer hours that are reasonable for the supported community? And whoops. And then it could also be, so hours is a good example. Another example would be if you live in an urban environment, someplace like Manchester, or you have a lot of people from a lot of different cultural backgrounds in those environments. So, So you have people that speak different languages, languages other than English. So do you have translation services so that if somebody shows up at the ED and you can't, and you don't have somebody that speaks their language on staff, do they have a translation service? It's kind of cool. They'll bring out, like, if they can't figure out what language you're speaking, they bring out a board that says, that has, point to the language that do you recognize this or something like, so it's like, it says, point to this if you recognize what this says or something like that. So you can, look at a dozen or 20 different languages and you're like, oh, okay, I point at that. And then they can say, okay, that, that person speaks Tagalog, and we're going to get the Tagalog translator on the phone. And then the last piece, acceptability, goes to cultural match, right? So when we've talked about this as well. So, there are cultural components, religious, ethnic, and so forth, where some processes are, or the service done in a culturally sensitive way. So those are all impact access, right? So it may be all four, the first four, it might be available, it might be accessible, it might be affordable. The hours are good, but the providers don't respect the cultural traditions of the individual who's seeking care, and so they just don't come. So those are dimensions of access. Now, a lot of times when we're talking about access, we talk about people getting insurance, and we worry about that. And there's a legitimate reason for worrying about that. Healthcare is super expensive, and if you don't have insurance, you probably can't afford it. So, thinking about, talking about insurance kind of in the same breath as talking about access has some meaning, but it is not the same thing. Having insurance is not the same thing as having access to care. And the reason that is you could be in a rural environment, have Medicare because you're over 65, and there might not be a hospital within a reasonable drive from your home. There may not be a doctor with, you might have to drive 50 miles to see a doctor. If you're poor and on Medicaid, a lot of physicians' practices don't take Medicaid. They just flat out don't, or they may limit the number of Medicaid patients that they're willing to accept. TRICARE is a similar situation. TRICARE has very low reimbursement. So TRICARE, to remind you, TRICARE is the insurance arm of the military health system. So we ran into, when we still use TRICARE, we regularly run into situations where providers won't take TRICARE because the reimbursement is so low. So if you have TRICARE, you have insurance. The problem is that it's hard to find. It's sometimes, depending on the type of provider you are looking for, a lot of providers just simply don't take TRICARE. So yes, you have insurance, but maybe you don't have access. Medicaid is probably the biggest problem with that, right? Medicaid has really lousy reimbursement. It's a hassle for the provider to get reimbursed. And so having Medicaid, nominally you have insurance, but providers don't want too many people like you in their practice. So you could have insurance, and then it could be that you don't have access because of geographic constraints, or it could be that the insurance that you have providers don't like, and so it becomes hard to find a provider that's willing to provide the care for you. Now, you can also have access without health insurance. So I mentioned the Surgery Center of Oklahoma. I talked about last time. This is a fee or a cash only provider. so that's a surgery center where they, you go in, you have a physician recommends that you get surgery. If you get it there, you pay a fixed fee, right? Another example is this thing called direct primary care. This is a really cool movement. It's also called concierge medicine. Direct primary care. Direct primary care, the way the direct primary care works is you pay a subscription to your primary care provider. So the fee might be $75 a month, $100 a month, $50 a month, something like that. You pay a fee every month to your provider. And usually the way it works is you basically have unlimited access to your provider. So there's a practice, there's a physician that I've met, and I did an interview with her a few years ago, who set up a practice like this in Portsmouth. I think it's called Freedom Family Practice or something like that. She's a solo practitioner. She has one part-time employee. She's got an office with one part-time employee who's a retired nurse who is a friend of hers, I think. And they kind of work together. But she charges, last time I looked at her website, she was charging $100 a month. So you sign up for $100 a month, you sign up for care with her. And she gives you 24/7 access to her. So you've got her cell phone, you've got her email, and you can see her as often as you want, talk to her as often as you want. If you need a lab or an X-ray, she has arrangements with providers for that you can get them at a discount, or so if you have insurance, the insurance company will pay whatever its usual fees are for your lab and your X-ray. So it's really cool. Like, I'm not feeling well. I just send my doctor a text, say, hey, I woke up this morning with cough and a runny nose. What do you think? And she'll text you back and say, you're probably okay. But if you feel worse later in the day, let me know, and I'll be in the office. Come in around 3, whatever. She doesn't do. I don't believe she doesn't do house calls, or she does if I think it's an additional fee. But basically, you can get access to her whenever you need. And so what this allows her to do is she doesn't have to have any infrastructure. She doesn't have to have a billing clerk, because you just sign up for a subscription. You just automatically pay her $100 a month. So she doesn't have to bill insurance. She doesn't have to do any billing, right? So that means she can eliminate all the administrative support. These practices tend to have very small panel, what we call panel. So the number of patients that she actually cares for tends to be very small. So the typical primary care physician has a panel of somewhere in the vicinity of 2,000 to 2,200 patients, which is a lot of people, right? So imagine giving 2,000 people your cell phone and your email and say, call whenever you feel, call whenever you need to. I'm around. You'd be like on the phone 24/7, right? You'd never get off. So these practices often have, instead of having a panel of 2,200 people, they have a panel of like 400 people. So now you've got, she only has to deal with 400 people. But if you take 400 times $100 per month, right, that's $40,000 a month times 12, right? Now you're $480,000 a year in revenue. And if all you have to do is pay your office rent and maybe a part-time employee out of that $480,000, probably doing okay, right? In fact, if you can get yourself up to a panel of 400 at that, $100 a month, you're probably making more than the average family medicine doctor that works in a large practice. So it's a different approach to, it creates a different and much more personal creates the potential for a different and much more personal approach to care. The question is, do you want to pay for that? Because most insurance, most insurance plans will not pay for a direct primary care subscription. So you would have to pay your regular health insurance and then pay, $1,200 a year for this subscription-based arrangement with your provider. So if you can afford that, it's a good deal. If you can get a high deductible plan, for example, that costs, say $1,000 less than maybe an HMO plan, then maybe the cost savings that you have from the high deductible plan, you could use to pay for a subscription-based direct primary care arrangement. Personally, I would love that arrangement. I mean, I have pretty good access to my primary care provider, but sometimes it's really hard to get in. I have the ability to send a message through my portal to the provider, but they don't get back to me that, it often takes 24, 48 hours to hear back. Certainly on the weekend, I'm not going to get a response. The response would be, if you have a emergency, go to an urgent care clinic, which, yay. I could do that. I don't need you to tell me that. So having that 24/7 access to this provider would be a really cool thing. Luckily, I'm healthy enough that I don't really have enough. I don't have enough going on medically that I would feel that I'd want to pay for that. But it would be I would like that, right? I would like that. And I would probably like it a lot if I was really if I had a lot of chronic conditions. And the physicians really like it because it allows them to spend a lot more time with their patient. So you come in, they can actually talk to you. They're like, hey, how's the wife and kids? How is your job? And really get to know you in a way that if your provider's on 15-minute, the gerbil wheel or the hamster wheel of 15-minute appointments, they just don't have the time to get to know you. And like I told you, I'm a terrible patient. Part of the reason I'm a terrible patient is I had a long history of really knowing my providers very well because I didn't just get to know them in a 15-minute, appointment. I would know them because we'd have lunch together in the hallway or talk in the hallways or whatever. And so coming out of that, in that world where I was working with my providers were my colleagues, coming into a world where I all I know is this person from, a handful of 15-minute appointments. She knows very little about me. When I go in to see her, I often have to, reiterate all my, conditions. She's got some records, but and she's a perfectly fine provider. And luckily, like I said, I don't have a lot of major concerns. But it's not the same thing as being able to, call your provider, spend an hour talking about, your family and other concerns, and them saying, sure, I've got the time because I only have 400 patients, right? So it's an interesting world, and it's becoming more common. So that's one example of what we call direct primary care, where it is a subscription-based service. But there are also a lot of providers who just go on a cash basis and don't take insurance. And it's interesting because I was just having this conversation with my sister when she was visiting, talking about behavioral health providers, so psychiatrists. Good luck finding a psychiatrist these days that's of any quality who actually takes insurance. Psychiatrists are in such demand these days that most psychiatrists simply just refuse to take insurance. They'll just tell you, hey, it's $400 to get in the door. If you don't want to, and you can just hand your credit card to my receptionist, and I'll give you a bill that you can submit to your insurance company, but I'm not going to deal with your insurance company, right? So many psychologists that like specialize in autism care, or or those sorts of or ADHD, they're able to charge far in excess of what insurance companies are willing to pay. And so they simply just say, I'm not going to take insurance. If you want the care, you're going to have to pay cash. And then you can try to get your insurance company to reimburse you for a piece of whatever I charged. So we're seeing that on the side of, cash for care, on the side of providers who are in high demand. And that's a lot right now, psychiatrists and psychologists. So psychologists who do the specialized testing, extremely high demand. And so they're able to basically just say, I'm not going to take insurance. I'm not going to negotiate with your insurance company. If you want the services, you have to pay for them. So again, having insurance won't get you access to that kind of provider. There are some psychiatrists and psychologists who will take insurance. I would say that the ones who are the highest demand, simply because of the level of demand, can basically just dictate the price that they're willing to take. So, but what I really like about the Surgery Center of Oklahoma is they're very patient-centered. They use the fact that they don't take insurance, that they don't spend money on dealing with insurance companies, and they simply just tell you, cash or credit, hand me a credit, either write me a check or hand me a credit card before you get your care. That reduces their expenses, and so then they can charge less for their care. Okay. In fact, I'm going to send this out. I'll send this out later today, but I will offer an extra credit, for listening to the Surgery Center of Oklahoma. It's an interview. I'll offer an extra credit for, what is this, exam 4. If you listen to the podcast, and I'll give you a short writing assignment to talk about what you learned, because I do think it's a really interesting approach that they have. So I'll send that out later today. Now, so you can have access to healthcare without health insurance. And one of the things that a company like the Surgery Center of Oklahoma does, or an organization like the Surgery Center of Oklahoma does, is they reduce costs. They make care inexpensive. Most care, having insurance, we've talked about how it insulates you, the consumer, from trying to make a decision between, do I want to get this care or not, right? What's interesting is, most care that's covered by insurance has continued to go up in cost over decades. What's interesting is the care that is typically not covered by insurance. So I don't know if any of you guys have had LASIK surgery, probably too young. But that's where they use lasers to zap your eyes, and then it fixes your vision. So you may get, if you wear glasses, you may be able, you may qualify for that kind of service, and it can have incredible effects. I had a good friend who had 2400 vision, right? So what that means is objects at 20 feet from her look like they're 400 feet away. So she tried to see it. She said she was basically blind until she put her glasses on. They did the LASIK and she had 20/20 vision. So it's life-changing, right? Well, when LASIK first came out, probably in the 90s, it was very expensive. It was, thousands of dollars per eye. And now it has fallen to less than $1,000 per eye. So it went from, in the 90s, being thousands of dollars per eye, to in the 2020s being less than $1,000 per eye, right? Most insurance companies will not pay for LASIK. So this is a thing you have to pay for out of pocket. And so the incentive, so ophthalmologists, right, eye doctor, physicians who are eye surgeons who do this procedure have been competing with each other and finding ways to drive down the cost, right, of providing this care. And not only has the cost of the care gone down, but the quality of the care has gone up. So what you're getting today both costs less than it did in real dollars, costs less than it did 30 years ago, and it's better. So the question is, why doesn't the rest of healthcare have that same function, right? Why isn't it cheaper to get, heart surgery today than it was 30 years ago? It's not, it's more expensive. Now you could say, well, it's better quality. Yes, but LASIK is also better quality and it's gone down in price. So these are the challenges that we have. And part of that, the answer to that dichotomy between is when a consumer is deciding based on price, there's a lot of pressure on the system to bring the price down. When you're getting something paid for through insurance, you don't care that much about the price that the provider charges. So then it becomes a fight between the insurance company and the provider. So, and this is the thing, you just see that as sort of this, because the insurance company negotiates the prices with the provider, what you see mostly is an increase in your overall premium and not a per procedure change. And so that tends to that smooth, so insurance is great in the sense that it smooths our expenditures because real insurance, it's unpredictable whether we're going to need it or not. But it also kind of hides from us the actual costs of things. So insurance, so kind of long, my point here is don't conflate, don't think of having insurance as the same thing as having access to care. You can have insurance and not have access, and you can have access without insurance. Now, most of us have insurance, and that's how we access care is by using providers that our insurance company says are okay. But it's not the same thing. All right. Almost done. I'm going to let you go. I'm going to let you go a little early. Usually I keep you right up to the hour. A little treat. All right. So, but the question is, but what about, Great Britain? What about England? They have free healthcare. Okay. So here's the thing about free healthcare, right? They exercise cost control. So we've got, on the one hand, central planning, and on the other hand, competitive market. So what happens in the National Health Service in a place like Great Britain, the extreme kind of other side where everything is done by the government? Well, the government decides everything. So political actors decide the structure of the healthcare, right? So we're back to the Donabedian model: structure, process, outcomes. So political actors kind of decide. So you elect some representatives, and they make some decisions about, where are we going to put a hospital, where are we going to put doctors, how much are we going to pay for it, and so forth. In a competitive market, in an ideal kind of free market, providers hyphen entrepreneurs. So providers who are out there, who are, physicians, for example, who want to both provide care, who want to make a living providing care, will try to compete with other providers to find a place where they can make a lot of money. So they will go places where there are holes in the market. So if there's a true free market, if there's a whole bunch of demand in a community for a physician of a particular type, and there's nobody currently meeting that need of that community, then that's a profit opportunity, right? If you're a physician, like let's say there's a community out in kind of, rural Maine that just has a huge need for LASIK surgery, and they're driving 100 miles to get LASIK surgery. Well, if you're a smart ophthalmologist who wants to make a bunch of money, you bring your practice up there, set something up, right? Even if it's not enough for, a full-time practice, well, then you get you rent a part-time practice up there, and, you do some practice there and you do some practice someplace else. The entrepreneurs will come up with all kinds of different ways of meeting customers' needs, because that's how they make money, right? So under a free market system, under a competitive market system, providers look for profit opportunities. They look for places where there are shortages of care, for example, and then they move there, right? Under a politically governed system, a system of central planning, politicians decide where they should go. So we talked about the Hill-Burton Act, and they said, what we need is X thousand, X number of hospital beds per thousand people. And then we realized, wow, that's really expensive. And we reversed our position on that, and suddenly started, hospitals were like, okay, if the government's going to pay for that many beds, then we'll build more hospitals. Then the government said, oops, that's really expensive. We're going to change the way we pay. And we're not going to pay for beds anymore. We're going to pay based on DRGs, right? When we talked about this in TEFRA in 1982, PPS in 1983, right? All that changed the system that hospitals have been responding to, because political actors had said, we want this many beds, instead of a competitive market where the entrepreneur provider would say, it seems like there's demand for more beds over here. Let's go build some. So that's the problem with that. Political actors determine what care is necessary, who is entitled to it, and how it should be delivered, right? So so then now you've got politicians deciding things like, well, you qualify for care if you're this age or this income, right? But if your income so that's Medicaid, right? So if your income crosses this level, then you don't get care, and you've got to figure something else out, right? Whereas under a competitive market, patients decide what they're willing to pay for, and they decide what's actually worth to them. And then one of the disadvantages of the competitive market, so a lot of times we talk about the central planning side is all about efficiency. Look, we've got duplicate care. We've got 2 nursing homes in this town. Neither one of them is completely full, right? So under a competitive market, you're going to wind up with duplication, because provider 1 is doing something, and provider 2 says, I think I could do that better. And he moves in next door and starts competing with provider 1. And that's often referred to as wasteful competition, because there's duplicate services there. I would say the outcome is, if one of those providers does better than the other, they'll knock the other one out. And the only way to get the better provider is to allow them to compete. Under most of the systems that we talked about, other than the United States, but also in the United States, right? Political actors then decide how much providers will be paid. So we've talked about this since the beginning of the class. Right? Why do we have an imbalance in the number of primary care providers and the number of specialty providers? Well, we have a system, Medicare, right, drives reimbursement, and reimbursement's based on our RVUs. And if you're a provider that does high RVU procedures, right, so you do a lot of procedures, you're going to get more RVUs and therefore more money than a provider who primarily does diagnostic and management. So specialists tend to do procedures. Primary care providers tend to do just diagnosis and care. So under a system that was built jointly between Health and Human Services and the American Medical Association, right, that's that RVU system, physicians who are specialists get compensated better than physicians who are generalists. Okay, so now if I'm going through medical school and I'm saying, I could become a family medicine doctor and make $220,000, $250,000 a year. Nothing to sneeze at. There's nothing wrong with that. But my colleague 2 doors down is making $800,000 a year because he's a orthopedic surgeon. It's hard to go to lunch with somebody that makes 3 times as much money as you. And you're like, I could have been you, right? That's tough, right? And so there's a fair amount of kind of professional jealousy that goes on. Like, I remember talking to a pediatrician and she was saying, my ophthalmology friend, literally makes 3 times as much money as I do. And she said, she doesn't work 3 times as hard as I do, right? But she makes 3 times as much money. So when I'm in medical school and I'm deciding, am I going to go to my ophthalmology residency or my pediatrics residency? And I kind of look in my crystal ball and I imagine, okay, I could make $200,000 a year or $600,000 a year for the rest of my professional life. Then you start imagining the lake house on Winnipesaukee and the vacation in Paris and sending your kids to private, to Phillips Exeter and, and the house in Rye and on, as opposed to a very, very good, like, it's not like you're eating cat food if you're making $200,000 a year, right? But it's not, the lake house in Winnipesaukee and so on and so forth, right? It's a good, solid income with a high level of comfort in your life, but you're going to have to sit next to the at lunch, when you're at lunch in the cafeteria at the hospital, you're going to be having to sit next to the person who's talking about got to get up to the lake house to open it up for the season. Oh, so hard to be me, right? So but that is not a result of market factors, right? That's not the result of a market outcome. That's a result of a heavy hand of the government saying, this is how we're going to compensate providers. And then we complain that we have too many specialists and not enough primary care doctors. So from a market perspective, prices emerge as providers compete with each other. Not enough primary care doctors, their wages go up, right? Too many specialists, wages go down. But if you have Medicare and other insurance companies intervening in that marketplace, in particular government providers intervening in that marketplace, the misallocations continue because it's being determined by politicians, not by the market. At the end of the day, right, the allocation of healthcare, health resources is allocated based on political power versus the ability and interest of patients to pay. Which one of those is fair? Well, so on the right side, poor people tend not to, don't have as much of a voice, right? And so they get less stuff. On the left side, you wind up with all sorts of misallocations and inefficiencies because political power. When I was stationed in Hawaii, trying to think of the guy's name, he passed away. He was a Senator Inouye, Japanese American, from Hawaii, served in World War II in a special. He was a war hero. Served in, you guys probably know this from history, but during World War II, there was a lot of prejudice against Japanese. We even interned something like 125,000 Japanese people for the crime of being Japanese, and they were American citizens. And President Roosevelt ordered them to be imprisoned for several years, whole families. And anyway, so it was kind of a special thing that he served in like an all Japanese unit that went to fight in Germany and on the Western Front. Right. Anyway, he was a very powerful senator, served for a long time. Served for a long time, very powerful senator. And it was kind of a joke in the military community because Senator Inouye, because he was so powerful, would direct things, would direct a lot of the federal budget towards Hawaii. And one of the ways that he would run things through through the system is he would do it as a military appropriation. It would be run, so it would be like a part of the military budget, but it would really be like a handout to his constituents in Hawaii. So we had, I'm trying to think of the name of it. There was this program that would send us, I don't know, a few $100,000. It wasn't a huge amount of money, but it was just, it was a symbol. And it was something like the green striped snake elimination program or something like that was called. And it was a payment of a couple $100,000 a year, and it would come in on our hospital budget, our military hospital budget. And then we would immediately turn around, transfer that to the state government. And it was just a handout to the state government. And it was supposed to be there were no snakes in Hawaii. There are no snakes in Hawaii. So the idea was to try to prevent snakes from somehow getting to Hawaii. You know, so like that was that crazy movie from the 90s with the snakes on a plane or something like that, right? So they didn't want to have any snakes on planes showing up and landing in Hawaii. So Senator Inouye, that was one of the many like little handouts that he would do to get goodies to his political supporters in Hawaii. There's just one of many things. So if you're a politically powerful person in our system, you can direct expenditures to your home. You will direct expenditures to your home state or your home community so that you keep on getting elected. So if the more you have a politically powerful person in a system that is run by the government, you're going to see allocation of resources based on those people's political power and political interests, not on the needs of the community. Right. So it's a balance, right? That's kind of what I want to say there about cost. So it's complicated, right? Cost, quality, access, it's complicated. All right, have a good day, good weekend. I'll send out that extra credit.